Hello, my name is Pojin Deng, and I'm joining everyone from the Mount Sinai Health System. And today it's my pleasure to have the opportunity to talk about the psychiatric manifestations and management in autoimmune limbic encephalitis. So thank you so much for listening and having me. Okay, so I just want to give a brief agenda for today's discussion. First, I want to talk a little bit about, in general, the neuropsychiatric manifestations in autoimmune encephalitis and how to organize them. And then a little bit about general principles of management of how to approach these cases. And then we'll talk a little bit, we'll finish up by discussing some of the specifics in both pharmacologic and non-pharmacologic treatment options. All right, so what in general causes psychiatric symptoms? Here again, I think we can try to break it down into two different domains, although realistically, these are not distinct, they're very much interrelated, but you can think about it by maybe there is some kind of problem in autoimmune encephalitis that affects the functional circuits in behavior and psychiatric pathology. Or, of course, as you can see here, maybe the problem is more granular on a neurotransmitter level. Maybe there's something that's changing in the synapse that's leading to psychiatric symptoms. And we'll go through them one by one. But again, I think the main takeaway is that there's overwhelmingly likely an interplay between these two systems. They're not distinct. Okay, so why don't we start by looking at it from a neuroanatomical and functional circuit perspective. So here, there are two theories that I want to touch on. The first one is in functional MRI and functional imaging research, where there's a building data that suggests that major limbic structures, key limbic structures such as the amygdala and the hippocampus serve as gatekeepers, which mediate downstream circuits that are involved in regulation and processing of emotion and cognition. In particular, there's more well-known studies that come from psychosis and schizophrenia about different ideas such as hypofrontality, that maybe that one of the key circuits that is being dysregulated in psychosis exists in the frontal lobe, and there's a decrease in activity in that circuit. Whereas maybe in some more positive symptoms of psychosis, that might be mediated by different circuits, including parts of the medial temporal lobe. The second theory or some of the second group of ideas that I want to touch on is that this is more emerging, but there is also building evidence that maybe there is some kind of loop that links our immune system, our emotion processing, our limbic system, and that it can often, in these kind of situations, in these clinical situations, it can become a little bit of a vicious cycle that some degree of autoimmunity or immune system dysfunction can lead to dysregulation of our limbic system emotion processing and vice versa. And that can also lead to dysfunction across these circuits. Okay, and here now, why don't we take it from the neurotransmitter perspective and take a look at that. So this is, I would say, maybe much more established in the sense that there are very well-researched theories into some of the different neurotransmitters that are involved in domains of psychiatric dysfunction. In particular, old dopaminergic and sympathoretinyl dysfunction theories in psychosis, and now building on that, new glutamatergic models and NMDA dysfunction. And you can see the same corollary ideas in anxiety and catatonia and mood disorders, that there is on different kinds of neurotransmitters that are dysfunctional on a synaptic level. And of course, I think this overlaps very well with the idea that in autoimmune limbic encephalitis, in many of these pathologies, that the underlying dysfunction is in these ionotropic metabotropic receptor antigen antibody binding complexes. All right, so how can we apply that in a clinical setting? How can we take that and use it to help treat patients? Well, here I'll start by focusing again on the early and prominent psychiatric symptoms pattern of presentation. Again, keeping in mind that there are different types and that they're not necessarily genotypically specific, but again, to try to focus on the most challenging clinical scenarios. And here, most research divides it into multiple stages. There's some research that focus on 4 or 5 stages, other papers divide into 2, but this is a fairly standard kind of presentation. And you can see that it's divided into the prodromal phase, the acute phase, and followed by recovery and chronic. And I think what's very important to keep in mind is the timing associated with some of these phases that really you have to incorporate that in your clinical decision making. So why don't we go through each phase and talk a little bit about what kind of psychiatric symptoms might predominate in each phase. So let me start with the prodrome and early acute phases, as these often go hand in hand. And if you look at literature into the prodromal phase, definitely in retrospective chart review, you can see that there often are these kind of insidious changes that happen, or very subtle changes that happen in functional level and cognition. But oftentimes, such as withdrawal from school and work, trouble with attention, concentration, and executive function. But oftentimes, this can be incredibly difficult to elicit and to identify due to the emergence of very prominent florid psychosis, and that disorganization and positive symptoms often can make it very challenging to identify some of the more insidious cognitive symptoms. And I think everyone will be very familiar with the idea that oftentimes these changes can be very refractory to antipsychotic treatment or treatment in general. Some of the things to be on the lookout for in particular during these phases are any kind of atypical components such as dysautonomia, rapid progression to catatonia, or refractory psychiatric symptoms, and of course, any kind of neurologic symptoms. As we go into the late acute phase, as we emerge out of the early period and enter the late acute phase, you can see here that this is when the clinical presentations can start to evolve in a very dramatic way. You can see in the arrows in the slide that I've tried to represent both the beginning, the onset of each individual specific clinical problem and the duration of time that it typically extends through. So you can see that in the leftmost arrows that psychosis often starts early during the end of the prodromal period into the early acute phase, and it extends all the way throughout to recovery. Agitation often goes along with it. And as you enter the late acute phase from the early acute phase, you can sometimes see the emergence of fulminant catatonia. And this, again, the same as with psychosis, this fulminant catatonia can often be poorly responsive to benzodiazepine treatment, to traditional treatment. And one other atypical feature is that this phase can often be marked by worsening dysautonomia. And this is often a phase when NMS or neuroleptic malignant syndrome or different kinds of psychotropic side effect complications becomes of great clinical concern. Okay, and this is in some percentage of cases, patients may go on to develop fulminant coma. Oftentimes in these cases, these are the patients who have a lot of kind of dystonic posturing. They have a lot of shouting and thrashing. And again, you can see that agitation continues all the way through these different phases. But in each of these different clinical syndromes, for example, in psychosis versus catatonia versus coma, the presentation of the agitation will be different. So it's important as you're for clinicians treating these cases to try to approach the management differently as well. Okay. The main thing that I want to highlight is that this is one of the very unique challenges, clinical challenges in this particular type of pattern of presentation, which is that we don't necessarily have great certainty about which patients might progress into which phases. In fact, one of the great clinical difficulties is that in some patients, even with appropriate treatment, even with successful immunomodulatory treatment, some patients will still progress through these fulminant phases. That doesn't necessarily mean that we're doing something clinically inappropriate. Okay, let me finish up by talking about the recovery and the chronic phase, which are not very well understood, some of the least well understood phases in autoimmune encephalitis. And what we can see is that in the recovery period, there is a stepwise reversal of some of the different neuropsychiatric symptoms, manifestations that occur. For example, If a patient has initially present with psychosis and then went on to develop catatonia, followed by fulminant a comatose state, then there is typically a stepwise reversal through these periods. And again, the underlying pathophysiological mechanism is not very well understood. What we're also starting to see is that while many patients do return to very close to their baseline level of functioning, premorbid level of functioning, and there are many patients have very insidious cognitive deficits that are long-term. In particular, some of the clinical syndromes that you can see are abulia, flattening of your affect, and akineticism. And it's unclear which risk factors really lead to this kind of outcome. Okay, so then why don't we move at this point to talking a little bit about the principles of management? So there are a couple of concepts that I want to emphasize and highlight. So I'm spending a lot of time talking about these scenarios where there are very prominent psychiatric symptoms. And why? Partly because if you look at research into this, a lot of these patients will initially present to psychiatric settings. And oftentimes, or historically, that can lead to a delay in care as patients are trying to undergo traditional psychotropic treatment, and it's proving to be refractory, or even potentially that they're developing complications or concern for complications like neuroleptic malignant syndrome that prompt an elevated level of care. So if you look at research into how to approach these patients with very prominent and early psychiatric symptoms, there is a well-established literature about how to break down different risk factors to prompt testing for autoimmune encephalitis. And here I've grouped them into, of course, the critical or the red box and the suspicious or the green box. I would say that it's relatively straightforward. And the critical abnormalities, of course, are if you have objective diagnostic testing markers in some of the major testing modalities like imaging findings, CSF findings, or EEG findings that suggest any kind of neurologic process. That should, of course, prompt a very thorough evaluation for autoimmune encephalitis, And then in a more gray zone area, there's the suspicious abnormalities. And here, I think this shouldn't be surprising, but again, include different components that we think of, like historically, that there isn't any history of psychiatric illness, and that there's a very abrupt onset of symptoms. That if there's any kind of viral prodrome or fevers or dysautonomia, that would suggest that there might be some other process that's underlying psychiatric symptom development. And then other things like refractory catatonia, refractory psychosis, or intolerance to antipsychotic administration is something that's been well described in the literature. That concern for neuroleptic malignant syndrome and refractory psychosis is often a reason to suspect that maybe there is an autoimmune process underlying what's going on. Moving forward into management and treatment, there are a couple of principles that I want to expound on. And let me go a little bit into the literature discussion before kind of emphasizing each of the components that I want to articulate. If you look at existing literature on treatment approaches in autoimmune encephalitis, the consensus is that in general, with ongoing inflammation, that the psychiatric symptoms are typically poorly responsive to attempted psychotropic treatment. Although this is a little bit unclear, and I'll talk about it in a second. But the bulk of this literature is in NMDA, which is of course the best described. But for example, if we take it as a case study, the idea in maybe an NMDA receptor encephalitis is that maybe when the NMDA receptor gets internalized and that leads to the subsequent glutamatergic dysfunction, that maybe that upstream dysregulation leads to a loss of normal inhibition of different kinds of dopaminergic pathways, in particular involving the ventral tegmental area and the mesolimbic dopaminergic pathway. And that perhaps because this kind of receptor internalization and network dysfunction happens at such a rapid and widespread pace, that maybe that's what's part of what's involved in reducing the effectiveness of traditional antipsychotic administration, like dopaminergic blockade of the positive symptoms of psychosis. But one of the things I want to emphasize about this is that we don't understand this very well, and there is some conflicting literature about this. So one of the major studies was done by Warren et al. In 2019, and they were, again, these are kind of low power studies, but they were looking at 25 cases of NMDA, and what they showed is that this was a larger retrospective chart analysis of antipsychotic treatment or psychotropic treatment in general, but one of the features they looked at specifically was how many people responded to antipsychotic treatment before and after immunomodulatory treatment, and what domains responded. And what they found was that there was meaningful reduction of agitation and aggression in both before and after immunosuppression, but there wasn't necessarily an improvement in some of the primary psychotic symptoms until after immunosuppression. And oftentimes after immunomodulatory treatment, there was a significant decline in the number of patients which required antipsychotic treatment. And compare that against a 2020 study where by Policanol, where they this was actually a larger study where they included almost 300 cases of first break psychosis. And they extracted the small segment of them that were ultimately found to be due to autoimmune encephalitis, which were 15 cases. And again, it's a small power, but in this paper, they were able to show that there was an equal treatment response in psychopathology, and there was an equal decline in psychosis scales for both groups. So I think that, again, suggests that this is an area of research that we don't understand. This is an area where we need better research. Okay, so let's go back to sort of the overall principles of guidance in management, and what kind of conclusions can we draw from this literature, if any. I would say that probably the most evidence is that early and sufficient immunomodulatory treatment and sufficient arrest of the inflammatory pathology is really probably the key factor in mitigation of psychiatric pathology. I think that intuitively makes sense, and that's borne out in the literature. The second principle that I want to emphasize is that especially for behavioral and psychiatric clinicians, the primary purpose of psychiatric treatment in autoimmune encephalitis is symptom mitigation and safety, and emphasis on the safety component. And really, when you are trying to approach what kinds of treatment modalities to effectively pursue that, your management needs to be adjusted based on, it needs to be sensitive to the current stage of encephalitis that you believe that you're in, and that the overall pattern, the overall clinical pattern of neuropsychiatric evolution should really guide your decision making. That really what we see is that clinicians have to be very nimble and very flexible depending on what's going on. Okay, so then let's talk a little bit about the details of how to do that. Okay, I want to start with antipsychotics because there is the most research and there's the most literature about this, and I think this is also one of the most tricky to navigate. Here at the top, I've included a kind of general guidance as to different branch points to decide whether or not you want to administer antipsychotics, how much you want to give and when, and what specific type of antipsychotic you want to deliver. And I really want to emphasize that first arrow, will agitation impair safety? Because this is a much more difficult clinical question than it may seem. Keep in mind that the type of agitation, depending on the current clinical stage of encephalitis, will vary tremendously. For example, the type of agitation that you see in florid psychosis will look very different than the type of agitation that you see in a comatose state or in a catatonic state. But you can imagine that at each of these different clinical stages, that the agitation can significantly affect the outcome and lead to a lot of complications in treatment. Okay, I think the rest of the arrows are relatively clear, but again, these are different branch points to help you decide: should I be aiming for a low potency agent? Should I be aiming for a high potency agent? For example, a low potency agent might be better if the overall goal is sedation, whereas a high potency agent there might, in theory, be better for increased behavioral, increased psychomotor agitation. versus do you want to consider an alternative like a benzodiazepine or a mood stabilizer? And should you be using them in kind of a standing or an as-needed approach? Let me focus a little bit on specific complications, because I think that these are the areas that really that tend to trip up clinicians the most. I think one of the most feared kind of complications in psychotropic treatment or antipsychotic treatment, specifically of limbic encephalitis, of course, is problems like a neuroleptic malignant syndrome and anticholinergic syndrome. Of course, you can see other drug-induced syndromes like DRESS. You can see EPS, although the overall incidence of these complications is unclear. There's probably the most literature into neuroleptic malignant syndrome. But I really want to go into the details because I think it's really important. All right. In particular, why does limbic encephalitis even have this association with neuroleptic malignant syndrome? So there are a couple different kind of working theories as to why. The first one is that maybe limbic encephalitis it itself is already this due to the kind of underlying pathology, this kind of dysregulation of ionotropic, metabotropic neurotransmitter receptors, that maybe that there is this you're already in this kind of hyperexcitatory state with a lot of excess sympathoadrenal dysfunction. And if you look at what's theorized to cause NMS in the first place, there is a tremendous overlap in the two. And there's also a continuum with this kind of malignant hyperthermia spectrum. And the thought process is that maybe in all of these kind of just pathologies that there is a common downstream effect, that there's ultimately this kind of disinhibited hyperexcitatory state with all this kind of sympathoadrenal dysfunction. And maybe that's where this kind of this clinical presentation that looks like neuroleptic malignant syndrome is coming from. But then also, if you think about it from kind of a neurotransmitter perspective, that if there already is going to be this kind of upstream dysfunction that leads to, that impairs kind of downstream inhibition of traditional dopaminergic pathways, such as your mesolimbic system, that maybe if you are in that kind of state already, that if you have abrupt dopaminergic kind of withdrawal, that might be a more kind of, that might prime you to enter a neuroleptic malignant syndrome kind of state. And one of the things I want to emphasize here is that it's not actually clear if the clinical complication that's happening in this kind of antipsychotic administration is actually NMS, or if it's just kind of an overlapping phenotype, as I was saying before. And to go into that, in particular, if from the Warren study that we were talking about before, one of the things that they tracked in particular was how many of those patients were transferred to different kinds of higher acuity settings for concern for neuroleptic malignant syndrome. And then there was a second paper actually done by the Warren team as well, where they did a chart analysis of a large number of cases, almost 150 or 109 cases. What they found was a little bit under a third of those cases, 42 cases, were suspected to have neuroleptic malignant syndrome. But if you look at if you look closely at what's happening in all these cases, what's happening is that all of these patients, this is happening before they are diagnosed with autoimmune encephalitis. And when they are transferred for concern for neuroleptic malignant syndrome, what's happening is that there is a further clinical evolution, which ultimately leads to the diagnosis of limbic encephalitis. Just to touch a little bit on the sort of spectrum of antipsychotics used in these papers, that really there was kind of a wide range of atypical antipsychotics. There were some first generation as well, but in general, the bulk of the antipsychotic agents that were chosen were atypical antipsychotics. Abilify, risperidone, olanzapine, and quetiapine were very common choices. And almost half of these cases had two or more agents, again, reflective of the idea that the agitation was extremely severe. Okay, all right. All right, so let's look a little bit about these specific atypical antipsychotics and what kind of how to use them. Okay, next I want to touch a little bit on benzodiazepines. They're pretty widely described in the limbic encephalitis literature, but one of the chief difficulties is that there's really little, if any, guidance on dosing or description of complications. And I think that that probably really reflects that there's a wide range of clinical presentations and uses of benzodiazepines, and that it can be difficult. They're not necessarily broadly applicable, or individual outcomes are not necessarily broadly applicable. But one thing I do want to note is that there is some animal model research that benzodiazepines do result in overall reduced neurotoxicity or reduced have some neuroprotective effects in encephalitis. In general, if you look at what agents are chosen in the literature, most agents are chosen due to onset of time or onset of clinical effect and duration of action, naturally. And oftentimes it's typically Ativan that's chosen, or Diazepam that's chosen, and it's used traditionally in a BID or TID dosing. And again, in the treatment of some of the complications such as fulminant catatonia, the dosing ranges that you can get to can be very high. The case reports have described even up to 20 or 30 milligrams a day. Some commonly cited alternatives include, you can see there, clonazepam, diazepam, and midazolam are probably the most commonly chosen alternatives. There are two kinds of, I would say anecdotally, there are two kinds of concerns that you run into when you are using benzodiazepines. The first one, one of the trickiest, is that it often, the amount of benzodiazepine that is required to try to mitigate some of these symptoms like agitation or catatonia can be so high that it often results in overall sedation, which can really impair your assessment of the overall functional status. You can imagine that in something very tricky like limbic encephalitis, where you're trying to make an assessment of whether or not what you're doing is clinically effective, this can be a big hindrance in care. The second component to navigate that I would like to highlight is that oftentimes, as a result of our earlier discussion about antipsychotics being having a lot of literature suggesting that there's needing to be a lot of caution in their use, that when we turn to benzodiazepines as a management of agitation, as a modality for management of agitation, that can lead to a really significant degree of fluctuation in symptoms, particularly in PRN use. And again, that can make overall assessment of the effectiveness of what you're doing very difficult to do. So in general, anecdotally, what I would suggest is that in the clinical use of benzodiazepines, that the management should be a very slow and steady up titration, and that PRN doses should really be reserved for situations of extreme agitation or situations where the level of arousal is not necessarily clinically is less clinically relevant or less crucial to ongoing management. I want to close this discussion of the psychotropic management with a couple ideas. I would say anecdotally, I would really encourage everyone to be very patient in these disorders, that oftentimes the timeline in these kind of conditions is measured in months, and really the anecdotal accounts suggest that the treatment approach and the management approach should not be reactive, that it should really be that clinicians need to make slow and steady medication changes and resist the urge to act very hastily, but at the same time also need to be very nimble. Okay, and how to do that, I would emphasize returning to assess the clinical evolution, the pattern of clinical evolution of psychiatric symptoms in these cases of encephalitis. Okay, I think I don't have enough time for the cases, so I think I will just close by I just want to close by saying thank you so much for listening. I hope that this was an informative discussion of some of the literature about management and management approaches. This is such an important area and fascinating and, obviously tremendously debilitating illness. And the more, I think as more and more people are becoming interested in the cognitive and psychiatric symptoms, I think that we'll be able to make much more progress. So thank you again for having me, and thank you for listening.